Good morning, everyone. I think we should get started. Welcome to Health for the World International Grand Rounds. Just a reminder for everyone to please mute themselves. My name is Caitlin Hackett. It is my honor to introduce today's speaker, Dr. Zarine Shah. Dr. Shah is an associate professor of radiology at The Ohio State University Medical Center in the Division of Abdomen Imaging. She is fellowship trained in abdominal imaging and nuclear medicine and has been on faculty at Ohio State since 2009. Her area of clinical focus is abdominal imaging with specific interest in hepatobiliary and pancreatic disorders, as well as MRI imaging of the prostate and bladder. She has active clinical research collaboration with colleagues in pancreatology and serves as the co-investigator and site radiologist for multi-institutional trials studying acute and chronic pancreatitis. She is active on the national disease-focused panels for chronic pancreatitis and pelvic floor dysfunction through the Society of Abdominal Radiology. So without further ado, I will turn it over to Dr. Shah.
Thank you, Dr. Hackett. Good morning, everyone. It is my honor and pleasure to be here and talking to so many folks across the globe. It is, in fact, amazing how we have come together and how we're able to connect over our virtual meetings now. And I think it has helped us get closer and learn from each other. So I am truly honored to be here and speak to you all about acute pancreatitis today. There was a talk a couple of weeks ago by one of our very esteemed and senior radiologists, and I don't want to repeat everything he said for those of you who might have been on that talk. So what I'll do is I'll go over very quickly a little bit about how acute pancreatitis is evaluated by imaging and the most recent terminology that we use for that. And then we'll kind of move over to more interesting cases and perhaps some management approaches and how imaging helps guide clinical treatment and management for patients. And then at the end, perhaps just for about 2 or 3 minutes, maybe go over autoimmune pancreatitis and then group pancreatitis. So I have no disclosures. And so as far as acute pancreatitis, for the definition and introduction, this is a fairly common disease. At least in the United States, it has accounted for about 275,000 hospital admissions. And this data is, of course, old, so the number is going to be different. But all the same, just kind of describes the magnitude of this disease process, the annual cost of about $3 billion per year. Clinically, by the American College of Gastroenterology, it has been defined as a patient having 2 of the following 3. So typical abdominal pain, which is epigastric, left upper quadrant, typically described as constant, radiating to the back, chest, or flanks, and a serum amylase and lipase level greater than 3 times the normal. 2 of these are enough to make the diagnosis. And the third thing that is used as a diagnostic finding is presence of changes of acute pancreatitis on CT, MRI, or ultrasound. So only 2 of the 3 are necessary to make this diagnosis for acute pancreatitis. As far as classification, there have been several different classifications that have evolved over time. The Atlanta classification that was developed in 1992 is now outdated because as imaging improves, as management changes over time, there is a new classification that has now been put together. This came together because of the work from Acute Pancreatitis Working Group. And in 2012, the revised Atlanta classification was put together, and that is what is now used to describe changes of pancreatitis. And there are 2 large buckets that this goes under. There is interstitial edematous pancreatitis, where there's diffuse edema of the gland, presence of inflammation involving the gland with or without fluid, and then typically resolution of symptoms within about a week or so. And then the more severe form, or necrotizing pancreatitis, which occurs in about 5 or 10% of the population. And as the name suggests, necrotizing pancreatitis is related to impaired perfusion of the pancreas or of the peripancreatic tissues, or both. These findings evolve over time, and we may see the changes of necrotizing pancreatitis as we image these patients over a period of time. Typically, these patients tend to be more sick and obviously get imaged more frequently to assess for complications. Imaging is overused, at least within the United States and perhaps in the developed countries. And 60 to 70% of patients who have typical abdominal pain and elevated enzymes still undergo CT or MRI within a very early onset of the disease. That's not always necessary. As I said, you need only 2 of the 3. And if the amylase and lipase is elevated and the abdominal pain is severe enough, that should suffice for the diagnosis, but patients often will get imaged. Imaging a patient very early with CT or MRI really does not change management, and only 1 to 2% of patients will demonstrate severe pancreatitis or the changes of pancreatitis early on. So the recommendations by the American College of Gastroenterology are that ultrasound should be done in patients who have acute pancreatitis to assess for a gallstone as an etiology. And then CT or MRI is only indicated early if the diagnosis is unclear and if the patient does not improve with management that is being performed. So moving on to the different types of fluid collections, these are again described and named based on the type of pancreatitis that the patient is diagnosed with. Patients who have interstitial edematous pancreatitis have there are 2 different names for the collections in this condition. The acute peripancreatic fluid collection, that is seen typically early in the disease process, so within days to maybe a couple of weeks to 3 weeks time frame. And then the late complication or the late presentation is that of a pseudocyst. Pseudocysts tend to typically form around 3 to 4 weeks when the collections have had time to encapsulate, and you can see a well-defined wall around these. Typically, they are simple fluid or maybe having just minimal complexity within them, and you can see them either inside or outside the pancreas or both. In the necrotizing pancreatitis variant, we can have the early collections, which are called acute necrotic collections. Again, ill-defined areas of necrosis involving either the pancreas or the peripancreatic tissues. And then the late complication or the late collection, which again, like in the interstitial type, forms about at 3 to 4 weeks, is described as walled-off necrosis. And like the name suggests, it has a clearly defined wall. Almost all of the collection, if not completely, has encapsulated to a large amount, and you can define a wall around it. The internal content is typically complex and heterogeneous, and we often see internal debris, hemorrhagic material, or just digested peripancreatic tissue within the collection. And again, it can be within or outside the gland. So with that background of the types of pancreatitis and what the collections are called, let's take a look at a few interesting cases, and that's going to be most of the talk from here on out. So this is a 62-year-old patient with recurrent acute pancreatitis, had a cholecystectomy, and has had a history of alcohol ingestion. So, enough alcohol that there was concern that that was the trigger for pancreatitis. Patient had abdominal pain and difficulty in eating. And as we can see here on this CT, the axial contrast-enhanced CT and a coronal image here, we have a very well circumscribed, fairly simple appearing fluid collection that abuts the pancreatic neck and extends anteriorly into the peripancreatic tissues, causes mass effect on the distal stomach, the pyloroduodenal region of the stomach, and causes compression on that lumen of the bowel at that level. So this patient had difficulty in eating and abdominal pain. So the thought was, let us do an ERCP to see where this collection is from. Is there a way this collection can be treated if we find out whether there is a duct communication? And rightly so, as you can see on this ERCP picture, that's the endoscope. The pancreatic duct has been cannulated, and you could see pooling of contrast within that collection. Of course, we are not filling the entire collection, but enough of the collection is being filled through a defect in the pancreatic duct, confirming that there is in fact duct leak. This patient underwent an open surgical cyst gastrostomy. So they basically went into the stomach and distal stomach and created a opening between the stomach and the wall of the cyst. And as you can see on these post-operative pictures here, that the collection has drained completely. And what we see here is that the gastric wall is tethered towards the pancreas. There is mild distension of that pancreatic duct in the body and tail upstream from where the collection was. So this is the patient after having had treatment with open surgical cyst gastrostomy. So another case here, this is a 46-year-old patient with acute pain, elevated lipase. So again, typical abdominal pain and elevated lipase. Not really an indication to image the patient, but this patient did get imaged quite early, day 2 of symptom onset. What do we see here? We have a somewhat edematous, bulky looking pancreas. There is inflammation in the peripancreatic tissues, a lot of fat stranding here adjacent to the gland. We see fat stranding at the level of the tail of the pancreas. And as we track up and down here, we see more inferiorly, more kind of ill-defined fluid in the peripancreatic region. Did we add anything to the diagnosis of pancreatitis? Not really, because subtle imaging signs may not be seen very early. And I'm going to point you to that subtle sign. Now, when we see the pancreas off to the left of this line here, and off to the left of this line, if you can appreciate, this part of the pancreas actually does not enhance as well as this little bit of pancreas at the tail. This is very early concern for necrotizing pancreatitis, a very difficult finding to pick up unless there is very strong clinical suspicion. This patient did eventually land up getting more scans because the patient was sick and did not improve with treatment. And this is day 22 of symptom onset. And as you can see here, the entire pancreatic head and body is almost completely necrosed. That's the part of the tail that looked fairly normal on, or relatively normal on that prior early CT scan. And then in addition to the pancreatic collection, there's also a very large collection in the peripancreatic region. So this is changes of acute pancreatitis with walled-off necrosis seen on day 22 of symptom onset. We say necrosis because the pancreas has been replaced by this large collection, and there has been basically autodigestion of the pancreas. We see that collection also extending slightly more inferiorly from the pancreatic head on the coronal images. So that case basically illustrates that very early imaging, you may miss it, you may feel reassured that the patient has only got interstitial pancreatitis when in fact it might be more severe. So if the patient is stable, waiting to get that first CT or first MRI is very important to understand the entire extent of the disease. So here is another case, 33-year-old with history of pancreatitis. We see walled-off necrosis with hemorrhage. And as you can see here, this is the collection fairly well circumscribed at the tail of the pancreas, again, replacing pancreatic parenchyma. So that tissue there is necrosed. And instead of that, there is a collection. As we can see here on the collection itself, inside there is heterogeneous high attenuation. So that is raising concern for perhaps internal hemorrhage or debris and necrosis at the tail. We see changes of acute pancreatitis in the posterior peripancreatic tissues. We see some thickening at the level of the stomach as well. So in this case, the CT actually provides us with adequate information. We have able to make the diagnosis of necrotizing pancreatitis. We are able to make the diagnosis of a walled off collection with internal heterogeneous debris. And it's important to be able to describe what's in the collection because treatment can be modified based on what you think will be drained out if you intend to drain these collections. So again, depending on what we see on the CT and how much information we are able to get, we may or may not need additional imaging. This is a patient who had symptoms of pancreatitis, but in contrast to the cases we saw earlier, if you look at the pancreas here, the pancreas actually looks quite normal. You see that normal feathery appearance of nobulations of the pancreas, same thing on this coronal image here. And a lot of the inflammation is in fact in the peripancreatic region. And what we see within this inflammatory tissue is low attenuation, which is probably a heterogeneous fluid, and then also lower attenuation internally, which are areas of peripancreatic fat necrosis. So what we are seeing here is an evolving collection, predominantly in the peripancreatic region, with a pancreas looking quite remarkably normal, considering how bad the peripancreatic inflammation is, and areas of heterogeneous internal fat attenuation suggestive of necrosis of peripancreatic tissues. Defining the extent of these collections, defining the location and the extent of involvement of the gland is important because patients who have extensive necrosis of the pancreas obviously do not do as well as those who have predominantly necrosis of the peripancreatic tissues alone. So prognostically, it is important for us to be able to define and determine where the inflammation is centered, how bad is the involvement of the pancreas itself. And for instance, in this patient, the inflammation is all in the peripancreatic tissues. Prognostically, this patient is likely to do much better than a patient with extensive pancreatic necrosis. So this is an interesting case. It's a 43-year-old lady with a history of idiopathic pancreatitis, and she continued to have pain day 18 of symptom onset. She really wasn't unstable clinically, but the pain just wasn't resolving. There is a collection here that we see at the level of the pancreas. We see the stenoportal confluence kind of at the back here. And when we put a cursor for internal attenuation on CT, the attenuation was pretty low. 7 is pretty much fluid attenuation. And so we were thinking of, okay, maybe this is just a simple pancreatic collection. It's causing some, a mass effect on the stomach, and just by the size of it, perhaps it's causing pain. But then you look at the coronals closely, and in addition to predominant low density, what you see here is there is, again, this internal heterogeneous sort of lower attenuation than fluid. And this raised concern that maybe this is not all simple fluid. Maybe the CT is just not giving us adequate information. And so we thought perhaps this patient will benefit from getting an MRI. In addition to the collection, we could also perhaps look at the pancreas, look at the duct, and see if we are able to see any other changes that will help management. So this is the MRI that the patient had, all T2 weighted scans, and just wanted to illustrate that the complexity of this collection with this heterogeneous low signal internal debris that we see on MRI was totally underestimated on CT. So as good as CT is, as quick as CT is, we may not be able to get all of the information. So if things don't match up, if things don't line up with the clinical symptoms, perhaps with how the patient is doing or the level of pain, consider doing advanced imaging if you think it's going to benefit the patient. It is definitely not indicated in every single case. And so we as radiologists should be knowledgeable enough to make that decision and advise our clinical colleagues that perhaps there is need for another set of pictures. Again, it's important to know what's in these collections, because when patients have persistent symptoms and you think about draining these collections, your clinical colleagues would appreciate knowing that when they go in and put a tube into this collection, either doing a percutaneous drainage or an endoscopic drainage procedure, they are aware that this is not going to be simple fluid that they can just aspirate. It's going to perhaps require wide bore catheters, perhaps placing stents across these collections, because the internal content is going to be pretty heterogeneous, gunky, a lot of debris that they may have to remove during the drainage procedure itself. So this patient continued to deteriorate, and we continue to do imaging on this patient. We see now the extent of the disease. We see how bad this necrosis is. On CT now, those areas are much better and more clearly visualized, and peripancreatic collections kind of becoming more evident as well. So this is a patient who had necrotizing pancreatitis with a complex collection, eventually did get drainage procedure performed. So this patient had alcoholic pancreatitis. We have a large collection in the pancreas at the level of the body and tail. And what we see here on coronal especially is you can see this pancreas is displaced inferiorly. You can see the head of the pancreas here, part of the body, and as we go across, the tail is pushed inferiorly by this large collection, which is predominantly superior to the pancreatic tissue. There is some inflammation in the peripancreatic region. Collection looks overall kind of low density. We again used our region of interest. It's about 12 Hounsfield units, so really not terribly concerning. But when we looked at the axial images, and this is not pancreas here, what we are seeing is some heterogeneous high attenuation internally within the collection along the dependent aspect. Again, not totally convinced it's a clear fluid collection. Patient had symptoms. We were like, is there something else going on? Is the patient bleeding into this collection? And so we considered doing an MRI. And on MRI here, the top two pictures are T2 weighted scans. We see that lobulated collection with a kind of a pocket off to the posterior aspect. And then on T1, what we see here is that there is internal high signal. This suggests internal hemorrhage and perhaps dense proteinaceous content within this collection, confirming that CT suspicion that it's not entirely just simple fluid. This is a contrast-enhanced image on T1, and we see that peripheral wall very clearly seen. We're not seeing any obvious internal mass, obviously, or any kind of vascular structure that's leading into it, but definitely presence of internal hemorrhage that is confirmed within this collection. The patient underwent an endoscopic procedure. So this picture here on the left is endoscopic ultrasound image that shows us the heterogeneous hemorrhagic content within the collection. This was the collection at the tail of the pancreas that we saw on the MRI. This is a picture of the endoscopic procedure where they placed a axios stent, which is a short metal stent that's placed across from the stomach or duodenum or a part of bowel into the cyst. And we have seen this is going into the cyst. They're draining out this turbid brownish colored material from the collection. And after the drainage was performed, what we see here is this axio stent, the metal stent, and short double pigtail catheters that go across the stent within the endoscopically created cyst gastrostomy that is kept in place to continue to drain any more fluid that may collect in that area of necrosis. So management of fluid collections, it is institutional dependent. There are variations based on your clinical colleagues, their level of clinical, I guess, acumen, how aggressive the surgeons may be, or how good your endoscopic team may be, and how advanced endoscopy is performed. But by and large, the concept of draining everything that you see is sort of becoming less and less prevalent. And in fact, there is now more push towards what is called the wait and watch approach, where if a patient is asymptomatic and you have a collection that appears sterile and it's not increasing in size, the general consensus now is that wait for this collection, see what happens, see how the patient does clinically. Don't jump to draining every collection that you see. Stabilize the patient, see if this collection resolves over time. Percutaneous and endoscopic drainage is certainly something that is considered and done quite frequently in these patients. And the typical indications are that patients have sepsis, failure to thrive, they're not able to eat, they keep continuing to lose weight. There is bowel obstruction or obstruction to the biliary system that results in jaundice and continued worsening of symptoms, persistent pain, or also as a bridging procedure prior to a definitive surgical management. So that's the condition when either percutaneous drainage or perhaps endoscopic, minimally invasive endoscopic drainage can be performed. And then surgical management, which is typically definitive treatment, it is done for patients who have clearly presented with infected necrosis, which is not controlled by less invasive measures. The collections are not accessible either because you can't put in a percutaneous tube, or for some reason, like maybe in a gastric bypass, you are not able to endoscopically actually get to that collection. Or if there are too many collections, and putting one drain is not going to solve the problem. Complications such as patients having obvious vascular rupture that you cannot treat perhaps by IR procedures, or large pseudoaneurysms that cannot be treated otherwise. So surgical management is clearly a more definitive treatment measure, but again, reserved for those patients who are not good candidates for other methods of treatment. So let's move over to vascular complications. We can see thrombosis, occlusion, pseudoaneurysm formation, and hemorrhage as vascular complications of pancreatitis. And I'll show you just a few cases to illustrate those. So here we have a 54-year-old patient who had alcoholic pancreatitis. And as we can see here, pancreas is clearly abnormal. We see a little bit of pancreatic tissue somewhere in, a little bit at the head, some of it here at the tail, a lot of complex looking loculated collections, many of which appear fairly well circumscribed and encapsulated. They're involving the pancreas, and some of which is tracking now into the inferior peripancreatic mesentery. We see a little bit of collection tracking off inferiorly to the pancreas here as well. This is consistent with a necrotizing pancreatitis with multiple loculated areas of walled-off necrosis. This patient had an open surgical cyst gastrostomy because we thought that there were too many collections. Perhaps a single drainage procedure would not have helped. So this is the post-operative image. And here is the stomach. We gave the patient oral contrast. The stomach, and this is the communication. This is actually the cyst gastrostomy that we are seeing draining that entire collection. So you see here that the collection has drained out, and most of the collection was cleared, in fact, at the time of the procedure. You can see staples here and a part of a surgical drain in the right upper quadrant as well. After the cyst gastrostomy procedure, they were happy. Everybody was like, oh, we got all the collections, patient should do better. But actually the patient then came back with GI bleed. And once the patient had that GI bleed, there was a question of, did we land up, is there a complication that we missed or did not pick up on? And so a CT angio was performed. And these are images from the CT angiogram. And what we can see here is clearly visualized extravasated contrast that is pooling here at the level of the pancreatic head. Based on its location, we were concerned this is an aneurysm of the gastroduodenal artery. We still see that surgical drain from the procedure that was done earlier. And these specks of air that we see within the pancreatic bed, I guess, is air from the cyst gastrostomy, since there is a wide communication with the stomach. So the patient had an angiogram. You can see a superselective cannulization of the hepatic artery. Here, they injected contrast, filled that pseudoaneurysm, and subsequently coiled the gastroduodenal artery, and the pseudoaneurysm was treated. So pseudoaneurysm is clear, definitely a complication. We should look out for things like oozing of contrast on our CT pictures, or complex collections, or then more advanced procedures like angios will help us make that diagnosis. This is a 39-year-old, 1 month out from the history of acute pancreatitis. Patient was not able to resume normal diet, doing okay otherwise, but could not eat, persistent pain. And understandably so. There are large collections that we see that are indenting on the stomach, indenting on the pyloroduodenal region, significant compromise and compression of the lumen of the bowel there. In fact, mild distension of the intrahepatic bile ducts as well. So this patient underwent an endoscopic procedure. And because if you can think about it, you get the endoscope down the stomach, there is a very, very short distance and easily approachable collection that you can place a stent into. So they put this axio stent, and this is how axio stents would look on CT. They are short metal stents, 2 flanges, one in the lumen of the bowel, one typically fits into the collection. We see a small pocket of air here that's related to the fact that now there is an iatrogenic fistula that has been created. The collection did get decompressed, so this large pocket is now much smaller. But there is this kind of vague high attenuation in the back. No oral contrast was given to this patient. So what happened exactly? This patient did have a vascular complication. This is a video of the angio that was done. And what you can see here is after injection of the hepatic artery, there is filling of the the contrast collection that pulls out of the vessel and actually tracks towards the axio stent. And here is the axio stent. And the patient was bleeding out from this stent. So again, a procedure that was performed via interventional radiology. We were able to coil this collection and treat that hemorrhage. This is a patient who has a very heterogeneous looking pancreas, very significant amount of debris within the pancreatic tissue. This is T1 where there's hyperintensity, so suggestive of hemorrhage. Almost no normal pancreatic tissue is seen at all. Patient was symptomatic. We were able to place again an endoscopic stent across the stomach into the pancreatic collection. And then what we see here actually is part of the orogastric tube, or the feeding tube that was in the patient. And the stent was placed. And when they did this procedure, during the actual endoscopic evaluation, they thought that perhaps they saw a vessel that was tracking very close to where the stent was. So they did not do any aggressive drainage. They did not try to do a necrosectomy, that is like debridement during the endoscopic procedure. They saw the vessel. They decided, okay, let's just put the stent and come out. And then we did a CT angio to see if we were able to find a clear vascular collection, a clear vascular structure in that region. And I'm going to scroll through slowly on this CT here. What we see is that we've got the enteric tube that's actually going in, and this was intentional. The tube was placed into the axio stent and was in fact placed into the collection. Here we see the axio stent going across, and as you see, large vascular structures are in fact tracking along that collection very, very close to the stent. So the CT angio did confirm the endoscopic finding and the concern of this large vessel going through. Now remember, these are not easy procedures. The patient is sick. There is a lot of debris, and what appears very obvious on CT to us may not be as easy for the endoscopist to pick up, because they're dealing with a lot of necrotic, in fact, ugly black material that just sits in there. So this patient did not, unfortunately, do very well despite the endoscopic drainage. The condition continued to worsen. And what we then noticed on subsequent scans were collections that were extending from the peripancreatic space into the abdominal wall. And you can see how there are fistulous tracts. There's a collection tracking along the left paracolic gutter. It's tracking along the abdominal wall here, extending into that left psoas and posterior abdominal wall, all the way out into the muscular layer. So this patient, in fact, continued to worsen despite attempts at endoscopic management. this was a case, I put it as an unknown because it was an unknown to me when it was presented at one of our multidisciplinary meetings. And what they showed us initially was this ERCP picture, and the endoscopist presented it as, we were concerned this patient with acute pancreatitis had a pancreatic duct leak, and we wanted to stent across the leak. And so we did an ERCP, and what we can see here on the ERCP pictures and what the endoscopist described was, once they put the scope in, they were able to get the biliary system to opacify nicely. And then they placed the wire across the pancreatic duct after cannulating the ampulla. And once they got it in there, they started to see a collection that was filling after PD cannulation. And they said, well, we tried to, place a stent across it. Nothing happened. The patient really didn't do very well. And with that picture, I'm like, this is not making sense. Why were you not able to easily drain something out if the patient truly had a collection? And so I started to look into the older scans. And this happens not infrequently, where we get one image provided and we are expected suddenly to help out. I think it's very important for us to realize that looking at old scans is going to be incredibly helpful to understand how the disease progressed and exactly what happened. And that's what I did in this patient. I went back to the first available set of pictures, and what we saw here on the MRI was a very small collection at the level of the pancreatic head. On the MRCP, we see the biliary system looks quite normal. The pancreatic duct is a little bit irregular, slightly maybe full or mildly dilated, and this small collection there. On the contrast-enhanced pictures, I saw here that there was a little bit of an indentation on the on the portal vein here. This is the stenoportal confluence. This is the beginning of the main portal vein. And then a few days later, the next set of pictures showed that the portal vein actually had a partial thrombus in it at the level of the confluence and proximal portal vein. And then on coronal images, this is that collection, the same collection that we see here. And the whole portal vein was thrombosed. So this patient developed portal vein thrombosis, but the collection was not that big. The pancreas did not look really that bad at all. So this is an MRCP data set that I'm going to run through here really quick, and I'm going to scroll through it slowly, try to appreciate the anatomy. We are looking at the intrahepatic T2 hyperintense structures, fairly distended intrahepatic T2 hyperintense structure. And we see that there are two sets of what appear to be ductal structures, one of which goes to the ampulla, the other one does not. That structure, the more distended one in the liver, actually tracks out, comes towards the splenoportal confluence, and that is the entirely thrombosed main portal vein that we see extending towards the posterior pancreatic body. And we also then see that the pancreatic duct, which is now what we are seeing in view centrally, is seen separate from that structure. So after this, we look back. This is the T2 weighted image. The entire main portal vein, the splenic vein, the stenoportal confluence is thrombosed. Contrast enhanced images showing us the extent of thrombus. Lots of collaterals at the porta hepatis because that entire main portal vein was thrombosed. In fact, even intrahepatic the right and left portals were not opacified with contrast. And this was what we saw on the contrast enhanced pictures. And that's when I realized what they had actually cannulated when they put in a wire into the pancreatic duct was in fact a fistulous communication with a thrombosed portal vein. And the contrast had been injected into the thrombosed portosplenic confluence and splenic vein. So this was a patient with a pancreaticoportal fistula that had developed as a result of what appeared to be a very small collection related to pancreatitis, but it was in the right spot. There was thrombosis of the portal vein and then a pancreaticoportal fistula that we were able to opacify. So I felt like a detective because this was the image that was shown to me, and then I had to go back and kind of try to figure out what really happened. Ultimately, when they realized what the situation was, they were able to, in fact, go back at endoscopy, not inject into this vascular structure, but in fact, get across the PD and stent it eventually. So moving on to the next type of complications, collections that can develop and can also have internal air density within them. And what are the possible etiologies for air? It can be related to infection and gas-forming organisms, presence of a fistula with bowel, either that's a spontaneous fistula or one that we create endoscopically or with open surgical procedures, so iatrogenic fistulization, or related to other interventions that we may have performed. So understanding the etiology for the air is important because if it's air and it's not infection, that collection need not be tampered with. You don't have to mess with it. Just thinking that air means infection. So this is the same patient I showed you several slides earlier, actually, the one that had very early necrotizing pancreatitis and large collections within the pancreas and in the peripancreatic region. And here we see, this is day 22 of symptom onset. We are seeing the tubular structure is within what remains of the pancreas. And it appeared on CT that it was perhaps communicating with this large collection in the peripancreatic space. So this patient, eventually, we didn't do anything. The patient was stable, ultimately came back. And on one of the set of pictures, we realized that the collection had decompressed. But now we see all of this air within the collection. Patient was not septic, was not having elevated white blood cell counts. And so this speckled air density that we saw was likely related to a fistula with bowel. What we see here are short tracts, and I can only show you one image, but when we scrolled through this data set, we were able to see multiple tiny tracts that were extending from that pancreatic collection into the duodenum. So this patient had spontaneously fistulized to the bowel, that collection had drained out, and what we saw was speckled air filling the cavity that was used to be the big collection. Another patient here, complex collection in the pancreatic body and tail. As we see, it's extending towards the splenic inferior pole of the spleen. Here you've got colon and you've got a loop of bowel here. These were small bowel loops, lots of air in the collection. So that raised question, did this patient spontaneously fistulize? Now remember, pancreatic collections have pancreatic enzymes. Those are enzymes meant to digest material. So as those leak out, they digest even peripancreatic tissues. They can eat through the wall of bowel as well. So what we see here is in fact a fistulous communication, not only with the colon, but also with small bowel loops and air in the pancreatic collection as a result of those fistulas. So again, understanding where the bowel is communicating with it is important. Patients who have fistulas with duodenum or proximal small bowel tend to have less symptoms than those who fistulize with colon, because if you have colonic material that's essentially feces pouring into a pancreatic collection, those patients are likely to be quite sick and not do as well as perhaps less, I guess, collections from the stomach and duodenum, which have less amount of gut bacteria in them. Here we see a tiny pocket of fluid after those collections were sort of almost spontaneously drained out, a little bit of contrast, and that confirms that this collection in fact communicated with the small bowel in addition to the colon. So this is a patient who had a history of pancreatitis 4 weeks ago, increasing pain. The pain was radiating to the back. And so after the initial CT where we saw a complex collection, patient persisted to have pain and then had severe pain in the back. When we imaged the patient here, we see again air within this collection that previously did not show air in it. And we were able to then demonstrate here after another scan that was done with oral contrast that contrast in fact pours into the collection. This was a fistula with a part of the colon that was extending in that region. We see contrast in the colon here, and that colonic loop was kind of straddling over the collection, fistulizing with it. So communicating again with colonic lumen. This is a case I just wanted to illustrate the use of Secretin-MRCP on. This patient was initially diagnosed at another hospital, was not getting better after the initial diagnosis of pancreatitis, and was transferred over to a larger center for management. We see here significant inflammation in the peripancreatic tissues, this large complex looking collection at the head and body of the pancreas. They were able to place an IR-based pigtail drain into the collection, and the collection did decompress, right? It's gotten so much smaller. But despite the collection almost completely collapsing, there was consistently high drain output. And when you see that, the concern is that the drain is actually, or the collection is actually because of a leak in the pancreatic duct, a leak that's big enough that the pancreatic juices continue to spill out of the drain. So in that case, this is not going to heal of itself, that just the pigtail catheter will not land up healing the patient. So we did a MRCP. We saw a little bit of that fluid that remained. Part of the pancreatic duct was opacified, but we really did not see much of the duct upstream from it. Secretin injection during that MRCP was done, and we can see increased distension of the duodenum. But what we also notice is that the collection fills up much more than the pre-secretin images. And in fact, we see high signal within the drain that was placed. That confirms that after secretin stimulation, pancreatic juices, in fact, were leaking from the pancreatic duct, spilling into that collection and draining out from that IR-placed pigtail drainage catheter. So that confirms the pancreatic duct leak. These leaks require to be stented. Sometimes they are far inside the gland, and stenting is not easy if the duct is not dilated. So these can be fairly challenging cases to treat. And if the endoscopists are not successful, they may require surgical management as well. There is clearly value for multiplanar imaging. You can see duct disruption, communications with ducts, obviously vascular complications, fistulas with the gut, etc. So our advanced imaging modalities are definitely helpful. They have a role to play in patient management for sure. So I think I have just about 3 or 4 minutes before it's the 45-minute mark. So I'm going to quickly go over autoimmune pancreatitis and groove pancreatitis. And again, this is not going to be by any means all inclusive. It's a very quick overview of these conditions. Autoimmune pancreatitis is a manifestation of a systemic IgG4 related disease. And it's a chronic fibroinflammatory process affecting multiple organs, pancreas being one of them, but the salivary gland, bile ducts, kidneys, lungs, retroperitoneum, lymph nodes, and mesentery can get involved. And on histology, what we see here is a typical description is lymphoplasmacytic infiltrates, swirling fibrosis, and obliterative phlebitis. So the venules that they see histologically are obliterated, and they see other imaging morphology suggestive of lymphoplasmacytic changes. Histologically, they have been described as type 1 and type 2. Again, these types are histologic, not imaging-based morphology, predominantly lobular, involving the lobules in the pancreas, and predominantly ductal. This is again based on pathologic assessment, not imaging. On imaging, autoimmune pancreatitis can either present as a diffuse process involving the entire gland. It can be focal, or you can sometimes see multifocal involvement of the gland with or without involvement of extrapancreatic tissues. And the typical description for autoimmune pancreatitis, which we see in about 40 to 50% of our patients, is a sausage-shaped enlargement of the gland. And by that, it means that the gland becomes featureless. You lose that feathery appearance of the pancreatic lobulations. The entire gland becomes smooth in contour. And you may or may not see what is described as a peripancreatic halo. That is a thin kind of a line that surrounds that edematous and bulky sausage-shaped pancreas, often seen on T2 imaging, often seen after contrast. Another finding that we see with this is if it's a diffuse involvement, the pancreatic tail may sometimes get retracted. So typically the tail goes all the way to the splenic hilum, but you may see that the tail gets pulled down and retracted. The pancreas almost looks short and stubby and sausage-shaped. So that is a diffuse pattern. In focal, imagine the same things, but not on the entire gland. And so you'll have a mass-like swelling or enlargement of the gland, often in the head, and you may or may not see some dilation of the pancreatic duct. That happens above the level of the enlargement. Now, as you can imagine, when you have duct dilation, that raises concern for an underlying mass. So these kinds of patients with focal pancreatitis from autoimmune disease can sometimes be a tricky condition to differentiate from and in fact be a pancreatic tumor. Just an example of a young patient with, this is a 17-year-old boy. And what we see here is that diffuse sausage-shaped thickening of the pancreas, looking on the axials, loss of that feathery pattern. We are seeing very subtle stranding and halo-like appearance. Right here, you see a little bit more of that. This is typical autoimmune pancreatitis. We are seeing a little bit of irregularity and mild dilation of the duct. Oftentimes, when you do ERCPs on these patients, the duct is in fact compressed and demonstrates multiple areas of compression and maybe a little bit of dilation in between, but a large majority of the duct is diffusely kind of irregular and compressed in the gland. And you can see a little bit of the duct here. This is MRI of the same patient, very heterogeneous, low T1 signal in the pancreas here, the body and tail. T2 signal is diffusely kind of increased, heterogeneous increased signal, irregular appearance of the duct, partly compressed here, mildly distended there. And again, that peripancreatic halo, like I was talking about, is this thin line that you see surrounding the pancreas. So these are imaging findings that are quite characteristic of autoimmune pancreatitis. If we are able to recognize this and confidently diagnose this, patients are put on steroids and do very well with steroids, especially when they are the typical presentation. They resolve, their glands often come back to almost normal looking pancreas, which may or may not see some atrophy. but these patients have different management based on our diagnosis and our sort of providing that input in the diagnosis of the patient. This is a focal pancreatitis, focal autoimmune pancreatitis. We see changes only here, body tail of the pancreas. You can see normal looking gland here, quite T2 hyperintense signal within the tail of the pancreas. This patient, we diagnosed her as acute autoimmune pancreatitis, continued to monitor her. She would get better with steroids and her symptoms would relapse. It kept happening multiple times to the extent where we ultimately questioned whether our diagnosis was correct. Are we missing something small in this patient? And she, in fact, had a distal pancreatectomy and splenectomy just because of her symptoms, and they kept recurring. It turned out on pathology, this was, in fact, just focal autoimmune pancreatitis. So the last thing I wanted to talk about was groove pancreatitis. It's also called paraduodenal pancreatitis. It is a relatively uncommon compared to the other kinds of pancreatitis. And what we see here is inflammation that's predominantly centered at the pancreaticoduodenal groove. Histologically, what is seen is that there is hyperplasia of the Brunner's glands and multiple small cysts or cystic structures or pseudocysts that develop in the pancreaticoduodenal groove fat. Pathogenesis is not exactly clear. We see it more in men, more with those who have a history of alcohol abuse, typically middle age in the demographic of that population. You can see a type which is predominantly only the pancreaticoduodenal groove involvement. That's the pure groove pancreatitis. But more often than not, what we see is a segmental involvement of the pancreaticoduodenal groove and the pancreatic head next to it. And oftentimes that duodenum is also inflamed and thickened. Patients may present with symptoms of acute pancreatitis or symptoms of duodenal and biliary obstruction, because as you can imagine, the pancreaticoduodenal groove is right by the ampulla. Your bile ducts can certainly get obstructed. And so patients may have a slightly different presentation for this. CT, we see ill-defined soft tissue in the pancreaticoduodenal groove, loss of that normal fat attenuation there, fullness in that region. We may or may not see enhancement. We may or may not see cysts. On MRI, we have a slightly better definition of the PD groove. And what we see is T2 hyperintense, T1 hypointense areas starting to look like little cysts that are forming in that region. Now, if the pancreatic head is involved and if it looks really bulky, there is certainly a possibility that all of the constellation of these findings together may present as if it's a pancreatic mass. And there have been multiple cases that we have discussed at meetings where we are looking at findings and discussing whether this is a tumor, should we do a Whipple, or is this definitely groove pancreatitis, and can we wait and see whether the patient gets better with treatment? Duodenal wall thickening and presence of cysts. If we see those features and the cysts are clearly seen, we tend to be more confident about our diagnosis for groove pancreatitis, but that's not always the case. To differentiate from adenocarcinoma, some of the features that may help us is when you see clear vascular involvement, more often that will occur with malignancy than with groove pancreatitis. Smooth strictures of the biliary system, which occur in groove pancreatitis as opposed to the abrupt cutoff that we see with masses at the pancreatic head. If we see cystic lesions, that definitely helps us to make the diagnosis of groove pancreatitis. And of course, follow-up imaging, if we can document improvement or stability, that clearly will help clinch the diagnosis as well. Just a couple of pictures here. So this is a T2-weighted MRI. What we see here is that typically we'd expect hyperintense fat in the groove between the pancreatic head and the duodenum. We are seeing that that is filled up with this T2 hypointense material here. When we fat suppress, we see subtle kind of increased T2 signal. On T1 imaging, this looks heterogeneously hypointense, and there is what looks like little peripheral enhancing, centrally maybe cystic areas that are seen in the groove. So these findings did raise suspicion for groove pancreatitis. The patient was conservatively managed, treated, and came back after 5 months. And we see that the PD groove now is seen much better. That inflammation has resolved. It's not normal, but it's much better than what we saw before. So this is a very early subtle imaging findings of groove pancreatitis that had eventually resolved with treatment. So that's all I have to share with you. Thank you all for being on this call and for listening. Hope you learned a little bit.
Thank you, Dr. Shah. That was excellent. I'd like to open it up to any questions that any of the participants might have, you can type them in the Q&A box at the bottom of the screen and I will read them for Dr. Shah. It looks like Dr. Dana Espinoza left a couple interesting references for us. Well, I don't see any questions yet, so I'll ask one. Dr. Shah, do you think there is any utility to adding a pancreatic phase scan to the typical single portal venous phase scans that we normally do to increase sensitivity for necrosis or an underlying mass or any arterial complications?
So I think yes and no, in the sense that yes, obviously doing more imaging, we can certainly pick up more findings, and especially vascular complications would be easier to see with that. But having said that, with the extent of or the number of patients that come through with pancreatitis, and a large majority of them not necessarily being necrotizing pancreatitis or ones with complications, I would say we need to defer and see what that patient does and how the treatment actually eventually sort of helps the patient. And if we find that there are more complications from it, then perhaps consider advanced imaging. Just doing multiphasic studies on patients who are presenting with a fairly run-of-the-mill, if I may say, symptoms of pancreatitis, perhaps is not going to have a very high yield. And we will end up obviously radiating the patient more, having more images to look at, which is not always bad, but can add to our work. And we may not really get too much benefit from it. For necrotizing, though, I would strongly recommend, when you have concern for that, consider talking to your clinical colleagues to wait and image those patients after that 3-day time frame. It is really, we're doing disservice to our patients if we scan them early. And this is a difficult conversation to have when you have clinical colleagues who are rather, in a sense of an urgency to image these patients. But I think it is our role as radiologists and as experts in this to try to convince them that we will actually be seeing more and helping the patients and helping management more if we waited the 2 or 3 days, especially when the diagnosis for pancreatitis has been made with other, clinical findings and labs, etc. So I think I definitely see our role as an advocate for the patient in that scenario, because what we will see when the patient does in fact have necrotizing pancreatitis can change management at that point, from patients doing a little better, starting them on oral feeds versus no, this is not just an acute interstitial, it's a necrotizing case. Let's wait, treat this patient, get them to stabilize even more and manage them that way. So.
Thank you.
Mm-hmm.
All right, I don't see any other questions yet. We've talked about sort of the role of rating for like 72 hours to look for necrotizing pancreatitis. It seems like, at least at our institution, they image these people quite a lot and sometimes with a fairly small window. Do you think we should be only imaging them every like 48 to 72 hours after their initial imaging to try to give them the opportunity to, declare themselves?
I definitely think that that is the case. So if the patients are clinically diagnosed, they are doing okay, stable, they are not, decompensating, then those patients are not the ones you want to bring into our imaging suites, and definitely don't want to image the patients multiple times just because they happen to be in the hospital and there's nothing else, that is happening to them. So a lot of the imaging orders that we see are at an institution like ours, where we have multiple specialties looking at patients. We have gastroenterology and pancreatology, and we have surgery, and we may have trauma critical care who saw the patient when the patient came to the ED. I think it's just the complexity of the way they are managed. But what we have tried to do is provide institutional guidelines that, in fact, we try to tell folks that please follow these guidelines. If you have questions, consult with us, so that we are not unnecessarily imaging the patients, not increasing the burden on the patient in terms of cost. We have healthcare costs that are picked up by insurance, but a lot of countries don't. Patients pay out of pocket. And so, people have to be judicious in using the imaging that they want to utilize for patient management. And that's where I think our role is so important, right? When you have CTs from before and they're requesting more scans, taking a look at that, taking a moment to talk to the clinical, the pancreatologist or the gastroenterologist who has sent the patient to you, and perhaps recommending either waiting or doing something different to see whether we can answer a question that they have clinically. So not a 28 or 30, 24 or 48 hour repeat CT perhaps is not always the answer.
Great. Eric has asked, can you comment please on your standard CT protocol for suspected pancreatitis, contrast dose timing, oral contrast, etc.?
So absolutely. So our typical CTs that we acquire for pancreatitis and just as follow-ups on these patients are portal venous phase scans. So we do these with an injection of about 100 cc's of contrast. That is imaged at about between 60 to 70 seconds after the injection. We do a single phase abdomen and pelvis exam. And I would say that typically these patients are quite sick when they are with severe abdominal pain. Oral contrast is helpful, but not always necessary. So we put it in our protocols, but we find that more often than not, patients don't drink it. And it honestly does not make a big difference in terms of what we can pick up and what we don't. Sometimes if you have a lot of inflammation around the gland, we may see some fluid that makes it hard for us to appreciate bowel wall. But when that IV contrast is on board, we are able to pick up bowel wall fairly well adjacent to it. Now, I would say in cases where, like I showed you, if there are collections that have air density in them and you're concerned for fistulous communications with bowel, I think in those situations, we use water soluble. We use Omnipaque diluted with water as our oral contrast. And that oral contrast is then going to be very helpful to make the diagnosis of a fistula versus an infected collection from a gas-forming organism. So depending on what you're looking for, we may or may not ask for that oral contrast and make sure it's on there. So hope that answers your question. And we do not, like Dr. Hackett asked earlier, we don't typically do multiphasic studies for our pancreatitis follow-up.
All right, I don't see any more questions, so I think we're almost out of time anyways.
Yep.
Thank you, Dr. Shah, so much for all of your insight. And thank you all for watching.
Thank you very much. It's been a pleasure. Thank you, Dr. Hackett. Have a good day. Bye.